And we'll go. So can I welcome you all to this meeting of the Highland Health and Social Care Committee. Can I just remind everyone that the meeting is being recorded and prompted by this meeting is being recorded sign at the top of the screen here. Anyone wishing to speak, just raise your hand, and if we can, avoid using the chat facility. And broadband permitting, it's easier to speak to a person rather than a little avatar, so if we can keep cameras on wherever possible. But having said that, I know I've got the wobbliest broadband going. Maybe just start off with a couple of apologies from me as the chair of the meeting. Probably one, apologies for the length of the agenda. We keep trying to take things off, but the things wanting to come on seem to defeat us, and I think we'll have to have a little think about that, Pam and I, with others, and the various timelines of the papers arriving, and I think that's just testament to the pressures across the system. It's through no lack of effort by authors in terms of trying to get papers into us, but there's just other things going on and priorities have to be assigned. So thank you to everyone for their forbearance for that. And final apology, but we're going to move Pam's Chief Officer report up the agenda, and that's going to follow immediately on the finance report. Because there's a clear linkage there between the transformation presentation, which Pam is going to take us through, following on from our last development session. And I think that will tie in rather nicely with some of the stuff which Elaine will talk about in articulating our financial position. I think those two items will run well. I am intending to take a break at some point through the agenda, but equally I'm sitting here with the vision of being finished by 4 o'clock. So So I'm going to ask speakers to be brief, but actually do make your points. Please ask your questions, because after all, that is what we're here for. Because we've got to give the papers robust review. So thank you very much for that, everyone. And Stephen, do we have any apologies today?
Just a quick note from Tim Ellison and David Fraser that they may have to leave early.
Thank you both. And I see Elaine has indicated that she may well need to leave early as well. Joe?
Apologies. Apologies from Louise Bissell. I'm here on her behalf this afternoon. She's on leave.
Thank you, Joe. Okay, we'll move on to declarations of conflict of interest. I won't read out the full sentence there, but members are asked to consider and reflect upon whether they have any conflict of interest in relation to any agenda item which they feel they need to declare. Nope, I'm seeing no hands there, so we will take it that there is no declarations of interest. We'll move on to the assurance report and the action plan from the meeting on June the 28th. So we'll start first of all with the assurance report, and I'll maybe just give anybody the opportunity first of all to raise any matters of accuracy that they may wish to raise on that the report of that meeting, which thank you to Philip for chairing on my behalf. Anne.
And just a small typo, Jerry, page 4. I think the two sentences just at the bottom, just above the box, are probably superfluous to requirements. I think they're just, Stephen's forgotten to delete them from his draft.
Ah, so. Yes, yep, see you there. Yes, they don't look as if they belong, do they? We will make that amendment, and if that's the only amendment, we will accept that report as a true record of our meeting, and I wrote it accordingly in the minute. I'll pick up the action plan, the rolling action plan, if I may, first before we go to matters arising from that minute. There's three matters on that which I think we can just pick up. Clinical governance and staff experience, we're proposing that we can remove those now, just in terms of clinical governance. As I said last time, I'd spoken to the chair of the Clinical Governance Committee and the Audit Committee just to alert them to our situation. But I leave Pam, you'll now be able to report that we've now developed a care governance framework.
Yes, we've had meetings. So Simon Steed, our Director of Adult Social Care, Claire Copeland, our Deputy Medical Director, and Fiona Duncan, our Chief Social Work Officer from the Highland Council, have had initial meetings. So Claire and Simon are taking this forward, and we've been developing a framework based on the framework that we already applied to our clinical governance system within our community services. And I'm happy for Claire to come in if you want her just to outline briefly the approach we're taking. Claire, would you be happy to do that? Thank you.
I think that'd be very useful. Thank you, Pam.
Yeah, sorry, I'm 5 minutes late and I came in when I heard the word framework, and then I've picked it up from there. So thanks, Pam. Yeah, we've actually had quite constructive conversations that I've mentioned before at a previous meeting, that we'd had positive dialogue, if you like. That's actually translated into meaningful action, which means we actually got around a virtual table to start planning out what that would look like. The plan is hopefully by the end of September, we'll be able to bring back something that actually will articulate what that looks like and how we'll link it into our clinical governance structure. There's a bit of nuance in terms of the detail, I think, is probably the fairest thing. That would be really remiss of me to give you that, and probably not the right thing forum to kind of go into that detail, but we're working through it, and actually it's been actually quite good as a kind of bringing together the two teams in terms of understanding our worlds and what's relevant in the kind of governance. But I think from what I heard, if you were talking about the Vincent framework, it aligns very closely to what we're trying to do with our social care, social work colleagues. And so we can bring you back something a little bit more detailed for the next meeting, if that would be helpful.
I think that'd be very, very helpful, Claire. Sure. I think as we've said before, it doesn't necessarily have to come through this committee, as long as it aligns with our governance procedures and it's reported. I think that's all we need. We need to be aware of that. So I think that would be very helpful, and we'll add that onto the work plan for the November. I think it's November the 1st meeting, Stephen.
Yeah, we'll definitely have something back to you about that then.
I'm already adding things to the agenda. See? The second one was the staff experience, and I think what we're suggesting there is we will just make sure that we involve staff as we go along. We make sure we use them at the development sessions. What I would like to give thought to, and maybe we'll pick this up in the development session, is how we can reintroduce back onto the agenda, actually getting that staff experience directly at the committee. But I don't think we're not losing sight of it, but I think we're managing to do that. And the integrated children's report, although we've got the children's plan on the agenda today, ostensibly for information and noting, we will have our mid-year delivery report on the November meeting, and we will bring that back then. So hopefully we can close that down at that point. Anyone want to make anyone happy that, or anyone unhappy that we close down the two items in grey? And we'll just leave the children's report open until we finally close it off at the November meeting. Not seeing any dissent there, so thank you very much. Now, do we have any matters arising from the assurance report of the previous meeting, which we would like to pick up? I've got one question for Pam in relation to our self-directed support report that we had at the last meeting, where we left it to go back to the senior leadership team and jog, Pam, in terms of, we were very supportive of the principle, where it was just it needed to go through that arena just to, in terms of the way forward. If you could just update us on that would be very helpful.
Thanks, Chair. I hadn't actually got in my head the update kind of sorted, because I've been focused on other things. I wondered if Simon could come in and provide an update, and I see he's got his hand up already. Thank you. Thanks, Simon.
Thank you, Simon.
So just to confirm, as per the direction of committee, this went through the senior leadership team of the Highland Health and Social Care Partnership to make sure it could be operationalised. That's the first point. Second point is that the arrangements are being put in place to allow change in the payment rates, and we're looking at that commencing from October. The third thing is that one of the reasons we're doing it in that way is to ensure that we are able to get in place the supports that need to be there to help people when they are wanting to set up their arrangements. I'll add a slight caution to that, because although we are keen to take this forward as quickly as we can, everything at the moment has to be caveated by whether or not we're able to actually recruit staff either to undertake the self-directed support for people or to provide the supports. But we're pretty confident about it at the moment. So that's been actioned, if that's okay with you, Chair.
Thank you very much indeed, Simon. That's very helpful. Any other matters arising on the assurance report that anyone would wish to pick up? I'm not seeing any hands, so we will move on to finance. And then, as I said earlier, what we'll then do is we'll immediately move into Pam's Chief Officer report, which will be principally around the transformation piece. Elaine, would you be kind enough to take us through the year-to-date financial position?
Yeah, Jerry, if it's okay, I'm going to share a slide deck which actually updates the position that's reported to month 4. When the papers were getting ready, we only had the month 3 position. So now that we're clear in month 4, I'd like to share that. Hopefully that's come up on screen. That come through? Yeah, good. So at the end of month 4, we're reporting a year-to-date overspend of just over 25.5 million, and we're forecasting that that's going to increase to 55.8 million at the end of the financial year. Within the year-to-date position, we're reporting slippage against the cost improvement programme of just over 8 million, but at this stage, we're reporting that with the exception of a small sum within Argyll and Bute, that we will achieve the full £29.5 million savings plan at the end of this financial year. So there is a risk associated with that, and I'll come on to that through the slides as well. So the position that we're reporting is nearly £13 million better than what was presented within the plan to government in March. And that reflects additional funding that we've received from Scottish Government for sustainability and NRAC parity. That is going to be a recurring element, and also new medicines funding as well. And the new medicines funding, it's anticipated that that will revert back to earlier years levels in 24-25. And the graph in the bottom left-hand corner there, the blue line shows the trajectory of where we expect it to be based on the plan that was submitted to government. The orange shows where we're plotting to up to the end of July, with that £13 million improvement set out just at that end point on the black line there. So focusing on the partnership itself, the year-to-date overspend of 4.49 is reported, and we're forecasting that will increase slightly to 5.4 at the end of the year, and that again takes account of slippage within the year-to-date position of cost improvement, but assumed delivery by the end of the financial year. Through the individual areas, within North Highland communities, the overspend 3 million forecast to increase to 7. We've got unfunded services there for chronic pain and enhanced community services. Both of these services are being reviewed, looking at bringing the overall cost of service delivery within the funding envelope. And across all areas here, we're seeing pressures coming through for supplementary staff, and in particular with our in-house care homes. For mental health, an overspend here of just over 3 million, forecast to increase to 3.8 by the end of the financial year. Main drivers here are locum and agency costs, significant high locum costs, particularly in the acute mental health setting. Within primary care, there's a slight overspend at the moment at 200,000, forecast to increase to 1.8 million. There's a couple of main drivers for that. Prescribing, we're forecasting an overspend of 1 million at the end of the year. And just to put that in a little bit of context, at the moment, we are about 3 months behind with prescribing information coming through from NSD. There's been a system update, which has meant they were paying 3 months in arrears on 3 months estimates. They're looking to get that resolved as quickly as possible, but at this point in time, there is a risk that that forecast overspend will increase significantly. And it's when you put some of the information that's coming through from NSD in a bit of context, you can see why. Routinely, there's about 8 million scripts processed nationally. At this point in the year, there's about 4 months of this calendar year where the number of scripts has been between 9 and 10 million. So a significant increase in the number of scripts, as well as the cost of drugs coming through as well. And also, we're still seeing that pressure within 2C practices for locum costs, where we're having difficulty recruiting GPs. Looking at the adult social care position, we've summarised the service categories here, and we're reporting a break-even forecast, but we need to put that into context that is supported by funding that Highland Council have been holding since the end of the 21-2022 financial year, and that this year will be the last year that funding will be available. So the figures reflect National Care Home contract uplift, which was agreed at 6.5%, and I think that came as quite a bit of a surprise to most of us in board. We are anticipating quite a challenging discussion around what the settlement is likely to be for 2024-2025, and that probably should be highlighted as a pressure as we go into that financial year. So a number of the original planning assumptions that we had around adult social care haven't materialised. Some of the sustainability payments that we've been putting to suppliers and assumption about how some of the care homes would be run haven't materialised at this stage. However, that's almost been cancelled out by an increase in a number of high cost packages, particularly within LD. So the independent sector are continuing experiencing sustainability challenges. They've got increasing costs and recruitment challenges, the same as we've got within NHS Highland, and we're continuing to work with the sector to provide support where possible. Going on to the savings programme, the pie chart here just breaks down that 29.5 million programme across the individual service areas. We've achieved at the end of month 4 1.7 million of savings, so there's a variance there year to date of 8 million, and the forecast overall is assuming 28.8 million of delivery, and the slippage within savings at this moment in time is all sitting within Argyll and Bute. The three horizons work was presented at the development session. It was very much in the early stages at that point in time, so that is still an emerging piece of work. But where we are at the moment is we've got an estimated full year value of schemes of 17.5 million. When that translates to what's deliverable in 23-24, we're looking at 9.8 million, so considerably under the 29.5 million, but the focus is still on getting ideas in place and working them through development and delivery. The table at the bottom splits the 29.5 million on a different basis. It's looking at all the work streams that form this Government Sustainability and Value Programme. So we've got an efficiency and transformation governance group that sits meeting bi-weekly. And at the end of month 4, as I've mentioned, 17.5 million on the tracker, translating to 9.8 million expected delivery this year. And of that 9.8 million, almost 6 million of that relates to schemes where we're looking to reduce supplementary staffing costs. So the main schemes in progress within the partnership are agency nursing, medical locums, prescribing, particular projects looking at wound management and continence products. The out of hours redesign that's been taking place and has been implemented in one area, looking at how that can be rolled out across the area, and also digital systems and how that can support delivery of savings and cost improvements across the whole area. The Efficiency and Transformation Governance Group is looking at 3 focus working groups. The first one looking at workforce, where we'll be looking at processes, rostering, safe staffing levels, and the review of locums and how that's all managed. For prescribing and drugs, they're looking at processes, challenge of new drugs and the high cost drugs and how those are approved and get onto the local formulary. Drug switches, trying to link it all back to realistic medicine work, and the issue around primary care prescribing, which it's unlikely we'll be able to make significant inroads this year, given the issue with increasing script numbers and costs. And then looking at digital and how we can maximise use of the systems that we've already got in place, such as e-rostering, order comms, patient hub, HEPMA and MS. Sorry, I've just noticed that says 265, it should be 365. I thought I had changed that. These working groups are all led by one of the executive leads and are being supported through the strategy and transformation team and finance as well as operational input. I've added a few tables in here around supplementary staffing. The table at the top left is for North Highland only at this point in time, just because of the way that we've been reporting. So an increase at this point in the year of just over 7 million through the same period last year. And despite all the work that we're trying to do to reduce supplementary staffing, what we've seen is that there was an acceleration of costs at the second half of last financial year, and we're seeing that carrying forward into the early part of this year, with the expectation that that will start to drop off from October. We're seeing a slight reduction from the graph at the bottom left, where the run rate is beginning to drop off slightly, with the exception of the partnership, but that's really been driven by an increase in the use of nursing agency within our in-house care homes at the moment. So when you take into account the Argyll and Bute position, we've got an overspend in pay at the end of month 4 of 2.4 million, and that's broken down across all the staff categories here. So an overspend of 2.4 million, but within that we've got nearly £22.6 million of supplementary staffing costs. So we can just see the impact that supplementary staffing has got on the overall financial position of the board. We've looked at the 12-month rolling rate for supplementary staffing, and your eyes right away will be drawn to that blip at month 10. But if everybody remembers, we had an issue with reporting due to a systems upgrade at the beginning of January, which has meant that that month 10 figure there should probably be smoothed across months 9, 10 and 11. So we're not seeing any notable improvement yet, but we are hoping that from month 5, when we've got a few measures in place, and also when we move into month 6, month 7, when we see the newly qualified nurses coming on, there'll be a reduced reliance on agency nursing staff. We're trying to track the movement in the forecast, so how the position's changing on a month-by-month basis. So at this point in time, it probably doesn't tell us too much because we're still in an early stage of the financial year. But based on plan, with that 68.7 million gap, 29.5 million of savings, come down to the 55.8, 28.8 delivery of savings in month 3, and it's reduced slightly to 55.8 million for gap in month 4, with savings increased slightly there. We've looked at the best, worst and likely case scenario. So the worst case scenario is assuming that we don't deliver any further savings, which could lead to an overspend of 87.8 million. At this point in time, we're focusing on a likely case scenario of 60% of the cost improvement programme delivered, which would allow us to deliver a forecast overspend of 66 million. And we'll keep tracking that on a monthly basis and bring that back. I've got a couple of slides here just on sustainability and value. So for the financial improvement group from Scottish Government, their August newsletters focused on 8 themes. So I've tried to kind of group them together here. So the ones in red, Discovery and Discovery Champions, NHS England, length of stay reports and PLICs, are all focusing on benchmarking nationally and looking at, looking at how NHS Scotland can better understand their cost base and manipulate that. The Admin Services Job Family Review, we've had a number of pieces of information coming from Scottish Government just about how our staffing levels have changed over the period. So focus on that this coming month is likely to be band 8s and band 9s. So looking to better understand how our staffing groups have drifted and increased over the years. Focus on the DTC analysis, so they're looking at how to improve financial engagement in area drug and therapeutic committees and how finance can play a part in some sort of decision making around getting high cost drugs onto formularies. The 2 in green, quarterly self-assessment and the financial improvement pack, are tools that Scottish Government are circulating to allow boards to compare against each other. So the financial improvement pack comes out on an ad hoc basis, and it's got ideas about things that we're generating across Scotland that we should be looking at implementing, or if we've already implemented, trying to feedback on how well that's going. And the quarterly self-assessment links into that, with Scottish Government on a quarterly basis circulating a questionnaire, which they're not expecting us to return, but it details all the initiatives that they've circulated, the ideas about, and asks us just how we've progressed that and whether it's something we're taking forward. So we're using that as a tool internally just to make sure that we're picking up on everything that we possibly can be. So Financial Improvement Group is that forum for generating and sharing ideas nationally. When these are shared, we're circulating to finance business partners who are then linking in with operational leads to see whether or not we can take that forward, whether we have done something in one particular area and whether we can spread that out across the board. And then how the board is engaging with the work of FIG forms part of that quarterly self-assessment process as well. There's a number of risks and mitigations that we need to consider as well. So supplementary staffing continues to be a significant risk for us. Despite all the work that's gone in, we are still seeing high levels of usage. Prescribing and drug costs, the adult social care pressures that have been mentioned. Inflation, whilst it's beginning to drop now, it's still at a high rate. And despite us putting significant increases into the plan this year for elements of utility costs, we are still seeing overspends coming through in that area. We've got mental health out of area placements continuing to drive costs, higher costs as well, and the delivery of savings is obviously a risk to us just now. But some of the things that are mitigating that, we've had reduced support and sustainability packages within adult social care. We're not saying that that's going to be the continuing position, but there may be some benefit there. We've seen a reduction in plan spend, and that's because we've reviewed business cases and some of the cost pressures and looked at how the costs are coming through this year, looking at whether there's slippage and taking that as a one-off benefit to the position, but also looking at that forward look to 24-25 to see whether or not we can reduce what we put in the plan over those 2 years. We've received some non-recurrent VAT rebates going back a few years, so that's playing into the position as well. And we've got that additional SG funding that's come through that I mentioned right at the beginning around sustainability and NRAP parity and the new medicines funding. And the final slide here is just around capital. So we've got a capital programme planned of 28.9 million. At this stage in the year, we've only got the formula allocation confirmed, so that's just under 7 million. Our main areas of spend so far are the final costs that are coming through for the National Treatment Centre, elements of estates backlog maintenance, some equipment purchase, and also the car park work that's going on at Raigmore. So that's the final slide. I'm happy to take any questions on that, and I will get Stephen to circulate these to everybody.
Thank you, Elaine. There really was a lot in there, and thank you for bringing us up to speed on the month 4 position. I'll maybe just throw it right open to committee members for any questions, clarifications they want to pick up. Philip?
Yes, thanks, and thanks for that, Elaine. It was quite a quick review, and the slides were quite small from my point of view with new glasses, so I apologise if I am asking you to repeat something. I got a wee bit confused in the cost improvement programme, where we have the global figure, we've got slippage, we've got where we are in achievement, the pipeline, and beyond the pipeline, we hope to achieve that 9.762. In terms of the health and social care cost improvement programme, could you maybe clarify for me where exactly we are in terms of what we need to do within that area of business rather than the kind of global, if that makes sense?
Yeah, no, that's fine, Philip. I will just get that up. Sorry, the slides have all gone to pot. And so within the partnership, there's a target of 10.7 million, and that includes 4.113 million within adult social care. So at this point in the year, we've achieved £555,000 worth of savings there. So there's a slippage of 3 million overall. We are forecasting that the full amount will be made at this time, but we know that there's a significant risk associated with that. So we're working through the ideas that are on the Horizons template to get a refined position. So that's an ongoing piece of work that we're looking at fortnightly at the Efficiency and Transformation Governance Group.
Thanks for that.
I've got Kay and then followed by Anne.
Hi, I just thought it might be helpful to put some of the things in context, because a lot of the themes of the meeting today are to do with staffing and things. I had 4 phone calls yesterday from care at home staff, one of which is retiring because of stress, one of which a young woman who enjoys the job, who got hurt on the job, is handed in a resignation yesterday because of the attitude of management. Had 2 phone calls about mileage. One person is doing over £1,000 a month, £1,000 miles a month. They love the job, but they've been almost offered a job in Inverness, and they were thinking, well, you know, I would just have to drive to Inverness and back. So can I sustain driving 1,000 miles a month for 25p a mile for the rest of the year until April? And this is the reality that you're facing, because especially when you've got private care providers, people are driving past the private care providers in order to get to the NHS ones. So, I mean, it's not a rural area. That person, I think, works out of Dingwall. So, you know, this is the reality of the staffing challenges that, you know.
Yeah, yes, thanks for that, Kay. I think absolutely, it's all of these factors at play, which is just bringing all this to a head. And
sorry, Jerry, my mouse kind of wasn't playing ball there. So thanks very much, Elaine, for all of that update. There was obviously quite a lot to take in there, but I think, you know, 2 things. One, I think it sort of does demonstrate the amount of activity that's taking place at a national level to try and support the boards locally, but also, you know, that whilst progress might be slow, that there's a lot of process and activity going on in terms of trying to understand our situation. And certainly some of that information, you know, is certainly some of the most detailed and, you know, that I've been able to see in recent times. So I think there's a lot of, you know, what you have presented there, which doesn't give comfort exactly, but I think does, you know, demonstrate the amount of effort that is going in at board and national level to try and address some of these issues. Because, you know, as Kay has graphically sort of pointed out, there are some things that are in terms of national, you know, the national competitive picture for recruitment that is really beyond our control. But we have to be absolutely certain that we are doing absolutely everything possible to address the things that are within our control. So I think Elaine's presentation has given me some assurance that you know, that we are doing that, or at least trying to do that. So thanks for that, Elaine. And indeed to everybody else behind the scenes. I'm sure it's obviously not all within Elaine's hands. So I do have a few questions, though, thoughts about what you presented, albeit a bit off the cuff. So that prescribing information that you gave us was really pretty significant. I wondered, do you think there's going to be any national work looking at that issue about the increase in scripts, and you know, what analysing that a bit more, so that it might give us some signs about discussions we might be able to have in primary care. That was one of my thoughts. It would be useful to maybe hear a little bit more about the learning disability situation and what exactly the issue is there, if it's locum, you know, and agency staffing issues, or if it's increased cost of packages for complexity. That would be helpful. But in terms of the bigger picture, I suppose, I guess the biggest thing that came to my mind was whether or not our assumption about full delivery of the savings is appropriate at this point in the year. And at what point would you normally expect to be looking at additional cost containment measures that might be necessary if we're not, you know, when we decide we're not going to hit that mark? Because in terms of the likely scenario that you presented of 60% of the savings targets, that's still a fairly long way away from that original plan. And certainly my understanding is that the Scottish Government's perspective on this is that the absolute bottom red line, if you like, is that we do bring ourselves in on plan. So if we were only to achieve 60% of savings targets, that would be a bit quite a way off that. So I guess what I'm saying is, you know, a bit of a challenge in terms of that assumption. How big is the risk? How red is the risk around delivery of the partnerships? Even the amount of, you know, the numbers that we already have as in delivery. And at what point might we have to start looking at any additional cost control to try and mitigate a gap in the savings target? Thanks.
I just come back, Jerry. It's okay. So the prescribing piece first, Dan, yeah, there's a national review planned. There's quite a lot of work going on nationally around prescribing before this situation even evolved. So looking at the national formulary, how we get drugs approved, but as part of the, I suppose, the review into what's happened with prescribing, the prescribing system, there is going to be a review taking place nationally around that, and it will mean that we've probably got access to a bit more information around prescribing as well when that all works through. Just taking them in order, if I can probably ask Simon to come in the LD position, if that's okay, once I've responded to the other questions. So the assumption on savings, I would say that at the moment I would rate that risk as red. We've taken that position at this early stage because we are still working through the plans for it. The additional cost containment is actually something that we're already considering. So already looking at how we, I suppose we don't like the phrase grip and control, but get a bit of grip and control around recruitment and how we're actually progressing with vacant posts and making sure we're really scrutinising all vacancies, not just new posts that are coming forward. We've not gone down the non-pay grip and control cost containment route at the moment, but these are all things that are sitting in the background that we might end up pulling forward. But I think when we get to month 6, so that's not that far away, we're just at the end of month 5 now. When we're looking at month 6 reporting, I think there will be that deeper dive into all the savings programmes, and we will come back with a refreshed position on what we forecast delivery to be. See, Arlene's put her camera on as well, so I don't know whether Arlene's going to come in on the LD packages or Simon.
Be very polite here and wait for each other to speak. It's not like us. Do you want me to go, Simon? Yeah, so I guess around about the provision of support for people with learning disabilities, it's those individuals with complex needs that have the most expensive, if you like, support package because of the requirement of the support. We do have a workshop which we've arranged for the end of the month looking at 2-to-1 support and when 2-to-1 support can be stepped down and what is good practice, and providing both assessors and our health staff around about some guidance about that, because that will help if we can cut back on some of the elements of the 2-to-1 support. We're also doing, I met with the council yesterday around about moving some of the individuals who are in isolated tenancies, as we would call them, so not in cluster buildings where we can have some elements of shared support. So you've got to have 24/7 and it needs to be just your person. If you live next door to some other people who are getting support, you can share particularly night support. We've met with the council around about getting some new clusters built and developed. None of that will be quick. You can't build new houses in a short period of time, but what we need to have that is in the planning, and we're also having conversations with some other providers beyond Highland Council about building for the future for new cluster development. But I guess it's that for individuals and to enable them to live in their own home, which is our strategic direction, and we're very committed to ensuring that people can stay in their own home, is that people require the support to do that. And what we need to do is make sure that we provide the support they require, but in the most effective way possible.
Anne, do you want to come back in?
Well, thanks, Arlene. So, you know, that it's useful to hear those mitigations. Was that, but I mean, was this overspend is that a carryover from a pressure from last year, or is it, you know, unexpected additional spend that we, you know, that or packages that we weren't aware of, or is it supplementary staffing because we have, you know, we've got gaps and those are rising?
So I would have to go into that. Yeah, I'd have to go into that in more detail with Elaine and kind of drill right down into it. It's not generally supplementary staffing because it's all commission services. So that all sits within the sector. There have been some instances with support providers who are really considerably seriously struggling with staffing, which I've heard many times in committee, and what we are doing is looking at, can we provide any additional support around about agency when they have to go to agency staff? Can we help kind of shore that up a little bit? But I don't think that would be what's fully covering this. I think it's probably around about the number of young people coming through transitions who are requiring 24/7 support, and at the point of, as a young adult, is often when they require their highest levels of support. And often as they go through adolescence and get into their sort of late 20s, early 30s, we can start to pull back on the amount of support there. So it's that kind of push through of the system of the young people that are coming through.
Okay, well, thanks for that. And I think it might be useful if we could, you know, it is a fairly substantial overspend in the context of the overall adult social care situation. So I think it might be useful to just next time round, if you could just confirm, you know, if you've managed to look at that in some detail in terms of what lies behind it. But thanks anyway. That it's good to, you know, it's good to know that we've got those mitigations being looked at, even if they might take some time to come to fruition. So thanks for that.
Sorry, Jerry, you're on silent, so I'm just going to talk over you. I think it would be helpful just to bring in Simon on the back.
Yeah.
Arlene's response before Kay. Thank you. Sorry.
Yeah, it was just to support really what Arlene was saying after we were being polite, letting each other go first. There's a couple of important factors to take into account here. The first is that since March 21, we've had 26 new packages that have been costing over 100,000 per year. So as Arlene was indicating, we're actually seeing a notable increase in expenditure, and that relates to that relates to people who previously might not have been receiving those kinds of packages. Second point is that as Arlene's also been saying, we talk a lot about care homes and care at home. We don't talk about support work quite so much in this committee. Support work is under very significant pressure and is beginning to show the fragility that we've seen already with care homes and care at home. So I would ask the committee to be mindful that the more that we have, as Arlene's described to you, in the way of isolated or separated tenancies, the greater the level of risk that is there. The third point I would make to you is that obviously we aren't seeing a growth in the number of people who are able to work in care. So one of the things that is now happening for us is that we are seeing an increase in the number of hours. So I would ask us to think not just in terms of money, but let's think about care hours as a currency that we need to describe. So we're seeing an increase in the utilisation of those within learning disability, and that's not matched by an increase in terms of particularly older people. So we're building an inequality there as we see that change taking place. And then the final observation I would make is that the points we made about the adult social care budget currently running towards a possible break-even position. A lot could go wrong with that. But even if it goes right and it does go to a break-even position, that's not break-even equitably across the system. That will mean that there's been significant increase in expenditure in relation to learning disability that's been offset by significant under expenditure in terms of older people. And the break-even position will be at the expense of unmet need. And I think the committee needs to understand that the savings at the moment are not savings that are sustainable planned savings. They're about non-delivery of service not because we don't want to, and not because we've got a moratorium, but quite simply because we cannot staff at the moment, and that brings with it a risk to people. I hope that's okay with you, Chair. Well, sorry, I don't hope that that's not an okay position at all, but I hope that's okay as an explanation.
Kay?
Hi, just to say that obviously with learning disabilities, rightly or wrongly, the change in the way that the care is provided and not having it centralised in a day centre or something like that, and rather than having people more in the community and at home, then obviously more people are needed to provide that service, and it's a more intense service because people who may need one-to-one at home could be in a group in a centre or whatever, where with lots of other people. So that change has made a big effect even on the home care providers, that they've had to employ more people in order to cover that shortfall as well. Whereas people used to be in the centre for the day, they wouldn't need to have staffing for that part of the day, and they do now. So it's led to an increase in staffing needs for all the sectors, you know.
Yeah, thank you for that, Kay. I've got Muriel, and then I've got Cara, and then I'm in the interest of time, I'm going to have to bring this very interesting discussion to a close, because I think we could probably keep going off. So we'll bring in Cara and then Muriel.
Hi everybody. Mine was really more a reflection. So I sit on funding panels, and we're often seeing packages just now for adults with learning disabilities with complex need, 24-hour support packages, requests and isolated tenancies. And I think that's for a number of different reasons. And I think there's something in what you're saying, Arlene and Simon, in terms of, you know, we're continuing to approve and fund these packages and progress, but then how we look at in terms of what we're developing and the long-term focus. And I think that's become quite difficult, I think. So it's probably something, you know, around the funding panels, and when we're looking at these packages, what are the themes and the direction as an organisation that we're progressing to, because I think we're seeing more and more through these funding panels, these requests, especially through transition. So I think it'd be helpful to consider that moving forward.
Thank you for that, Cara. Thank you. Muriel, give you the final word.
No, apologies for my late arrival, and apologies if this has been covered. I think I start to get rather nervous when, and Simon always is so articulate in how he describes things, but the building of the inequalities, where are we sitting in the risk register with that? And, you know, we have got hard facts, but I think we need to start looking. I know we need to start looking at how the service will be delivered down the line, but where are we with the here and now, and how urgently do we need to act? Because it is a real concern. Unmet need usually indicates that there'll be some crisis intervention required, and I really think that's not a good thing at all. Thank you.
Yeah, I think that's an excellent point, Muriel, isn't it? The unmet need and the expanding inequalities gap. I think that's a really good point. I'm going to break my promise. I've got Kay and I've
Oh.
got Simon, and then I will close it down.
I just wanted to come, it's a sort of similar theme, that about the funding packages for young people, one thing and another, that historically a few years ago that families got support as well by, you know, knowing that the young person would have daycare or whatever. So therefore, historically, most people lived at home with parents, and if that support's not put in, then families, you know, aren't getting that support to go out to work, to, you know, and have their own life, and therefore it could lead to more packages be, you know, 24-hour packages having to be sought after. So that needs to be thought of, as well as, you know, sort of how do we support the families, and because it's cheaper for people to stay at home with the family from an NHS point of view. So, you know, that support package for the family to, before we get into 24-hour support, sort of.
Thank you, Kay. Simon.
Dead quick, just to answer Councillor Coburn's point and give the committee a degree of assurance. A report in relation to the specific risks that we were just describing to the partnership is being prepared, or has actually been prepared and is being reviewed at the moment by the Chief Officer and by Fiona Duncan from the Council as a joint report to go to the Joint Monitoring Committee at its next meeting. So it's just to confirm that in terms of a risk that is being very explicitly addressed across the partnership as opposed to within the Health and Social Care Committee setting.
Thank you very much, Simon. Okay, we'll bring that item to a close, although we're going to talk about some of those themes a little bit more now as we move into PAMS. But first of all, in terms of the year-to-date financial position, what we're actually been asked to do is to discuss, and I think we've certainly done that, and note the NHS Highland and the partnership financial position at month 3, and Elaine has very helpfully updated us to month 4, and take from that report and discussions limited assurance. Are we happy to do that?
Not sure happy is the right word, but we'll do it.
Content, I might say, content to take limited assurance. And I think we've had a good articulation of the risks there. So thank you very much to Elaine and all the contributors there. I think that was a really full discussion. We'll move on not so swiftly to Pam and the Chief Officer's report, Pam. And I'll leave it to you whether you take the couple of little bits first or do your presentation on the transformation element first. Oh. Pam's frozen on my screen, so I suspect there's a problem going on somewhere.
Can you hear me?
I can hear you, Pam, yes. But
Yeah,
I can't see,
okay.
but you're not moving.
Oh, is that better? Okay, I'm going to take us through a transformation programme of work that I presented at the NHS board yesterday. So I'll add wider context. So I'm going to do that quite quickly and try not to repeat some of the discussion that we've already had that will be in the presentation. So I wanted that to be a substantial part of the Chief Officer report because it brings in the redesigns and transformation and things that we're going forward. And within that, you know, part of our transformation programme would be around the Ross Memorial Hospital changes that are going there in terms of the fire compliance work. But what I did want to highlight was the Scottish Social Services Awards. They're just now open for nominations. So I wanted to make sure that everybody had the link. And despite the challenges we've just been focused on financially and in terms of the workforce, there's a lot of hard work, there's a lot of innovative work going on in terms of how our adult social care workforce are developing and delivering services and transforming people's lives, by working in partnership, for example, with housing and some of the models that Arlene was articulating around learning disabilities. So, I think we should all be key in looking at the social services awards and looking at the criteria and nominating individuals, please. So that's just a plea. I think valuing our workforce in these challenging times is really, really important. So I will just share my screen then, and I'm going to take us through this presentation that I did to the NHS board yesterday. Normally, the thing to do would have been to take the presentation to this committee for discussion and then on to the NHS board. But of course, the way that our meetings fell, that wasn't quite possible. But I shall just go on to full screen now. If somebody can just shout out, because I'll not be able to hear yet. If you can just see that on presentation mode. It usually just takes a minute to get itself going. The slideshow.
Not yet.
I think it's doing
there.
something.
It's there, but it's
there. Okay.
Not in presentation mode yet.
Yeah, I think it's just come on my screen.
Oh, yep, there you are.
Has it done it? Good.
Yep.
Okay. So I think it's important then just to remind us that we've got our sort of foundation within the board, the Together We Care With You For You strategy, where we've done a lot of public engagement around service delivery and transformation going forward. A key document that's actually for discussion later on in the committee is the annual performance report, and that's a pivotal document for us, because for the first time we've been articulating delivery against previous years, our performance against the National Health and Wellbeing outcomes. So from an adult social care point of view, from a community point of view, in terms of mental health services, primary care, etc., we're able to tell a story about where we are and what areas of outcomes we've delivered on and where we need to focus our energies and our efforts going forward. So that's really important, and I'll let Rhiannon take you through that as we proceed with the agenda. But key and pivotal is the joint strategic plan with the Highland Council, and having that public conversation. We've got a lot of challenges, as we've heard. There are financial challenges, there's workforce challenges. We've got that increasing workforce costs of agency to try and maintain current levels of service, which just aren't sustainable. Excuse me. Excuse me. So, anything that we can do to transform our services is the key articulation that we want to make. So, when Elaine was outlining the work that we're doing in terms of Horizon 1, what we really need to have an eye on is the longer term planning that's going to get us to Horizon 2 and 3, which are going to be our transformation plans, and workforce redesign and team integration and service integration and service development are all the big key hitting sort of models that we're looking at. And the Horizon 1 work that we're undertaking are really helping build that foundation for us to get there. We've done a deep dive into services, so that we know about our unfunded posts. We've had we've been working on technology and digital solutions. We know how things can help us. We've got the cost containment models there in terms of agency, but translating that from the workforce bit from the financial bit into the costs into the workforce development bit, because we just don't have the labour market there, and often we have a burden on corporate services, if you like, to keep recruiting to posts that in the labour market they're just not there. We don't have GPs in the labour market to recruit to, but we continually try and recruit. So we really need to look at ourselves and look at our organisation and look at the services that we need to deliver for our population, and redesign workforce and integrate workforce teams for better sustainability and better efficiency and responses in terms of our health and care services our population. And that really needs a good conversation with our public, with our citizens, with our carers, and with our staff as well. So taking forward the strategic plan and the engagement is absolutely key. And we know from our internal analysis and audit that we don't have the right systems in place in terms of locality planning and or our community planning partnerships. An example of where we didn't quite get things right would be the temporary closure of the Macintosh Centre. So, for example, things happening very quickly when we were forced into a situation of not being able to staff the centre, compounded by the fact that other care homes around about the area, we couldn't pull staff from staff or services that we would normally do to be resilient. And we ended up in a temporary closure situation where we hadn't been able to have that conversation with the public and our politicians and our elected members, and B, with the residents and staff themselves. We kind of fell into it very, very urgently with acute workforce challenges in a remote setting where a care home became vulnerable. So I just want to emphasise that what we're doing in Horizon 1 is the foundation, and we must take the public with us, we must take our workforce with us, we must take our carers with us, and everybody needs to have all hands to the pump. Just reflecting on the time, just now it's 2 o'clock and we've been talking about this for an hour. It's an important area for us. And it's really good that people are engaged in this agenda, because through our co-production and our collaborative working, those are the elements that will help us get there from a leadership and an engagement perspective. So that's kind of just an opening statement that in a frame that I just wanted to give. So I'm going to run through this presentation really quickly, hoping that it'll start to move on now. Has it moved on? It hasn't moved on my screen. Can somebody tell me?
No, it's not moved on. It's not.
No. Okay, thank you. Has it moved on now?
It has. Yeah, it has now.
Thank you, Anne and Muriel. Thank you. So, I want to talk about the strategic areas for transformation and efficiency, and you'll see at the bottom there I put in the original cost. That's what we started off with in April, and we've been looking at our workforce, the buildings that we deliver care from, the amount of beds that we've got through which we deliver that care, and in terms of the resources, not only financial resources, but things like our digital technology enablers, our contracts, etc. One point that I want to make is that it's not beds that actually deliver services to people in a care setting. It's actually the people, it's the workforce. So, we often try and keep beds open and keep people in beds and staff beds, and we try and staff community at the same time. And that's a real challenge for us in terms of an ageing hospital estate. When we've got a strategy, home is best, but I guess the public still want to retain, hospitals, and they're very emotive about hospital bases. And this is not about closing hospitals, this is about using our buildings in the best and most efficient way. So I want to say at the outset, there's not an agenda to close hospital here, but we may want to change hospitals into community hubs like we're doing in the north, which looks like a really successful and well collaborative design, co-produced model going forward, making sure that we weave in services and new innovations such as technology in people's home, and we work from a hub. We've got hospital at home services under design, etc. So we still want to stick with this jigsaw in terms of articulating the big headings around the transformation, but the context is important. So we've got four areas of Horizon 1 work underway, which Elaine's already articulated quite well. We've got unscheduled care, we've got cost containment, we've got contracts, and we've got digital under the 4 headings. And of course, unscheduled care is a big area of focus for community services. So, we are looking at out of hours redesign and aligning our primary care, emergency centre and FNC, for example. There's a huge onus on the community to get that right, on community services to collaborate and get that right. And, the kind of there's whole system pressure and demand that we're experiencing across the system, and you know, emergency and urgent care within acute hospitals are really feeling the pressure with people coming towards them. So getting the unscheduled care elements of our plan is really important. So we've been reviewing our urgent and unscheduled care programme board, and I'll come on to that in a minute. And we've got winter planning readiness underway. I've got a quick update to do about our approach to that in a later agenda item. And we're aligning our functions to support transformation delivery. So within the community, we need an element of leadership support. We need an element of business support. And we've got the right people in our structures. We just don't have them in the right place. So aligning some of our function to deliver on some of our Horizon work is going to be really important. Integration is a key one. We need a care home strategy, and we need intent about our strategy, particularly around, you know, where we're going to develop and deliver care homes in a changing care home market, where the market conditions have actually changed very, very significantly, and we've been forced to react to that over the past year. And we've already had the discussion about the staffing challenges within them. So we need to work more collaboratively, and we need to review and plan care home capacity so that people don't wait in hospitals. And I know that Jill at the last development session we had talked a lot about the 2C practice management and the developments and the conversation that started there. And you know, we know we've got a number of GP vacancies that we can't recruit to, so we really need to try and do something difficult and different in that space. That was almost a throwback. So cost containment, you know, we've had Elaine's outlined all of the issues that we're doing to address all of them, and we're working at pace. We're really engaged around the unfunded posts, the vacancy control principles, stopping recruiting to vacancies we can't fill, looking at workforce redesign at pace. So really being engaged with our people partners on that agenda, and Horizon scanning out for other organisations. In terms of contracts, we're looking at reassessing care at home packages, new contract arrangements, which we're developing and testing. And we need to change where care at home is prescribed. We had a consensus workshop last week for both of the senior leadership teams across acute and community. And that was a really important workforce workshop for us to understand the challenges that each part of our organisation has, really, in terms of, you know, that consensus. You know, there's a lot of anxiety from the acute hospital about maybe a lack of community resource, you know, a lack of packages and people waiting in the acute sector, and a lot of conveyance to hospital resulting in admissions and people being delayed in care, and all of the adverse care elements that creates. So it was good to all be in the room to hear the challenges, but also to hear about some of the opportunities and some of the design thinking, and some of the redesign of the urgent and unscheduled care work streams that's going to get us there. And of course, we've got our digital technology enabled care, when we're working in partnership with housing, when we're looking at how we deliver care. Then, you know, we've got a number of elements that we're looking at, in addition to the e-rostering, etc., and the HECMA and the Microsoft 365 you know, extensions and deliveries that Elaine mentioned in her presentation. So Horizon 1 you know, has been our deep dive, has been our analysis, is our cost containment, is, you know, a lot about getting our house in order to set us up for success for Horizons 2 and 3. So the key work streams that are underpinning Horizon 2 and 3. So the strategic redesign programmes, I always bring an update about the status for the Caithness Hospital, the North Hubs, the Lochaber and the Skye programmes. You know, so they're developing well at pace. I've not brought an update specifically about them, but there are challenges in terms of staffing some of these models. There are you know, workforce redesigns and robust workforce plans that we need to take forward. So that's the main part that I would advise the committee about. And in terms of our urgent and unscheduled care programme board, we did have 8 high impact changes articulated by the government. So there were 8 models of care that we were focused on in terms of delivering. We've had some support from the Centre for Sustainable Delivery. So they spent some time with us early this month, and they came to find out about what we were doing in Highland by way of a sort of having a conversation and an in-depth look. And they're now delivering 5 portfolios around community urgent care, flow navigation, hospital at home, front door flow, and optimising flow. And those were the 5 portfolios on which we had consensus across acute and senior community services, senior leadership teams last week, again, making sure that we're going in the right direction, that we've got the right systems in place, and that we can deliver at pace on these. So that work's being taken forward. So in terms of Horizons 2 and 3, there are strategic transformation outputs. They refer back to our joint strategic plan. So again, we can't emphasise enough how much the conversation and engagement about getting that plan absolutely right is needed, because we need to have an implementation plan that will get us to where we need to be in terms of transforming our services and transforming our services and delivering them within the resources that we currently have. So, we need to articulate the system of health and care, particularly at district level, and what that can generate, that kind of integrated team design. Integration is just not about NHS Highland and the Highland Council lead agency arrangements. There's lots of integrations to be done across our own organisation, and we need to do that with our strategic change programme as a result of our joint strategic plan implementation. We need to optimise our collective resource to deliver health and social care outcomes for people. Whole system, balanced system. We hear a lot about different parts of the system being in crisis in terms of, community services and people having to wait for care and no care home placements, whole system pressure. I don't think there's a need to dilute the language. I think there's a need to put it into context in terms of, we're in the same situation nationally. There was a winter summit held last week as well, just to look at the whole system across Scotland, as we enter into winter planning. And of course, we know that winter planning happens every year, but actually we're experiencing reactivity to whole year pressures in terms of the different sectors where we lose workforce. So we need to optimise, and we need to work in a whole system and a balanced system. And we did have a really good workshop last week. And there are some anxieties following that workshop from what people heard and how what they think about the changes. But we are the leaders, we are the change. So a lot of work to be done at pace. We need to make sure that our integration arrangements are inclusive of all our community partners. So, our GPs, pharmacy, optometry and dental. And of course, we've already heard from Elaine earlier about some of the engagement that we're having with pharmacy around transformational change. And the digital element comes into that as well. So making everything linked together for good outcomes is really important. We want to shift unscheduled care to scheduled care, and it's within our gift to do that with the systems that we've got, particularly out of our system, our flow navigation centres, and our collaborative working. So we really are in a good position to move unscheduled care to scheduled. And, in Horizon 2 and 3, we want to have a standard of no delays. So we've got a lot of challenges to overcome, but we've got a lot of redesign and delivery to do. We should all be up for the challenge and working collaboratively, engaging with our communities about what's required, and how we can work with people in an upstream way, in a preventative care way, keeping our population healthy and well. There's lots and lots of elements to help us achieve our transformation outcomes. So I'll just stop there, and hopefully that's just put a bit more sort of transformation feedback from the session that was held, the development session that was held, and adds more context and more strategically and transformation plans wise onto the facts and the figures and the programmes that Elaine's just outlined for you. And I'll stop there. Thank you.
Thank you very much, Pam. And that was really informative, and I think it just demonstrates further that the real wealth of work that's going on across the entire system. And although we've spoken about it today in the context of following on from the financial position, I think the message that's coming across very clearly to me is the challenges are not purely financial. We actually need to go through this transformation journey to ensure that we have a sustainable, equitable system and service moving forward. We've touched very briefly on the expanding inequalities gap because the dangers of doing things in an unplanned and an unforeseen manner. So I think that to actually have that framework wrapped around it is really really helpful. I'll very quickly throw open to anybody who wants to make any comments or raise any questions. But again, I'm conscious of time, and we spent an hour on this very important topic, and I think rightly. But I'll very quickly throw it open to anybody who wants to raise any points. Joanne.
Thanks, Chair. Pam, it was just a question around assurance that the communication is including the third sector and external partners. It's not very clear from your presentation that they're included, although you speak about integration and taking everybody along on the journey. I just wondered if you could give me some assurance that that's taking place. Thank you.
Absolutely, I would want to give you that assurance, and it's more implicit than explicit. I could have spoken about a lot of other stakeholders, who are going to help us get there, including the public. So yes, I should have made specific reference to the third sector, but that assurance is there, and hopefully, you are engaged in the community councils, the community planning partnerships, and the significant redesigns that are going on, across the organisation. So happy to reassure you about that. Thanks, Joanne. It's a good point.
Anyone else? Nope. We'll move on. We'll keep this very much on the agenda in terms of how we moving forward, and obviously we'll speak about it in financial terms. But I think as we develop and get involved in the development of the joint strategy, and we'll see it in the mental health strategy, which we're going to talk about later, I think we'll see all these factors coming through. So just in terms of closing off the formality of the Chief Officer's report, so really taking on board what we've spoken about there, is there any matters that anyone feels that we need to seek further assurance on or escalate to the NHS board? I don't think there's... Anne?
Could I just ask, I was interested in what Simon was saying about the preparation of a report that would be going to the Joint Monitoring Committee. I just wondered where within the board that report would appear, what the plans were about that.
Simon and or Pam, I'll leave that one for you to pick up.
Simon, are you there? Simon, are you there, Simon? Thank you.
I'm here. It's at the moment, all I understand is it's a report going to the Joint Monitoring Committee.
Okay, well, I think can I ask then that Simon and Pam discuss that the appropriate route for that report. I may have got this wrong, but it sounded to me like it was a report which was, I suppose, addressing the risks and that we face in terms of the pressures within the system. So obviously, I'm not sure, whether that would come up through the new care governance arrangements that are being talked about or what. But I think it would be useful to to know
Yeah.
where it might appear in the NHS Highland system.
So so the process is that we'll meet tomorrow as joint officers, and we'll discuss, because we need to prepare the reports that are going to the joint monitoring committee, and there is a plan to take a risk report. Remember the service risks that I outlined the last time at the DMC? They were around risk to services, but we didn't have the whole context or agreed joint risks in terms of finance and workforce, etc. So it's to scope that out a bit. So we need to take that to JOG for a discussion tomorrow, and we haven't actually bottomed out what we are taking to the GMC.
Okay.
So that would be the first process. Yeah.
Thank you for that, and I'll pick that.
Thanks.
I'll put myself down to pick that up with Pam once I've had the appropriate discussions at JOG, and make sure if required it goes through the board protocols. So I'll take it from that. There's nothing we wish to escalate to the board, although we will make sure that the board are and they already are, but we will reinforce the message in terms of the scale of the work ongoing and actually the risks in the system. So thank you very much. Apologies, that's my dog sitting beside me, not me. It's making that noise. I've got biscuits sitting here that he wants them all in one go. So we'll move on to the primary care overview report. And before we get into this discussion, just say this report purposely does not include work on the primary care improvement programme and all that entails, because we're going to have a substantive agenda item at our next meeting where we'll cover all aspects of the primary care improvement programme, because actually it would probably take over and dwarf the update. But this was really following on from our dental update. I thought it was important just to get an update on the other aspects of primary care and family health services, which are ongoing as well. So we will pick up the primary care improvement programme at our next meeting in a full and substantive item. But I'll hand over to, I think, is it Jill that's picking this one up?
Yeah, thanks, Chair. You've got me today to run you through the update.
Thank you very much indeed.
Not at all. So I think there's a really good piece of news there around community optometry and the extension of the services. Cora MacLeod, who's our optometric advisor, works both in the hospital setting and also in the community setting, and that's across Highland and Argyll and Bute. Cora has been seconded to Scottish Government and has obviously been involved in the development of the community glaucoma service. So it's really great to see this coming forward and developing, extending the skills of our community optometrists across the community setting. You'll see there's some interest there. So we've already got accredited providers who have signed up. So in 2024, next year, they're going to roll out an enhanced service where patients can be followed up and routinely monitored within the community setting. So I think that's a really good news story. That's been tested early in advance of 2024 in some of our Argyll and Bute practices. So it's really, really helpful to see that in development. It was delayed by COVID. It was due to be implemented a year ago, but obviously it's great to see it come to fruition and reality now. Again, just some ongoing discussions around the electronic patient record for optometry, and also discussions around stroke and TIA pathway. So it's really good to see community optometry develop and link into more of our clinical pathways. From a dental perspective, I know there was an extensive discussion at last meeting. John gave a very comprehensive update in terms of access. Just a couple of points to note that we have had some practices that have opened their lists and are accepting new registrations for adult and children patients. That's Invergordon, Alness and Tain. And also Fort William and Glencoe Dental Practice are obviously now accepting new child registrations. So we're seeing some changes in access, which I think is all positive. As John would have talked previously about the new contract for dentistry, it's been talked about for some time. I think it was also delayed as a consequence of COVID, but now detail on that has been published, has been shared with our providers, and Scottish Government are looking to implement this for the 1st of November. So I think the hope amongst the profession is that that's going to be more attractive for dentists to actually offer NHS services and improve the access position that we've currently got at the moment. So we're seeing that as a positive. And also another positive move, so the Scottish Dental Access Initiative grant, that's funding that Scottish Government made available for practices to apply for to extend their practices. And obviously we've had one, which is for a new dental practice in Inverness, and that went through the assessment process on the 21st of August. Not had a formal update, but I don't see any reason why the team would have not supported that application. So any use of Scottish Government funding that's available to improve access, I think, is welcome for us in North Highland. In regards to general practice, we'll bring a comprehensive PKIP report at next meeting. But from the board managed GP practices, we had another practice that made the transition from GMS to a board managed arrangement. That was from July 2023. That was the small practice Armadale Medical Practice, which was run by 2 part-time GP partners. They both decided to retire. We worked very closely with them to re-advertise the practice. They weren't able to secure a provider coming forward, so that transferred to board management from the beginning of July. I think Pam already referenced, we've got a significant number of GP vacancies across the board managed practices. This isn't something that is, singly applicable to the board managed practices. I think Neil commented at the last meeting that actually all practices are struggling with recruitment at the moment. In particular, we've got vacancies in Scowrie, Downess, Kinlochbervie, the Three Harbours practice in Caithness, which is one of the Thurso practices, one of the Wick practices, and the Leibster practice, which we've merged together. And then another significant hotspot is Valness and Invergordon. And I think colleagues have mentioned where we have vacancies and we're relying on recruitment as our mitigation, our reliance on locums is quite significant in those areas. And as Elaine mentioned, we've got a cost pressure in terms of that supplementary staffing around GP locums. Just another point which to highlight, as part of the new GP contract, there was a premises directions included within that, and there's a process that we put in place which reports in through our asset management group, whereby practices can apply to the board to transfer the lease of their premises to the board. There's a process that we've developed to go through, and we've had some expressions of interest. The aim of the lease assignation scheme is to make it more attractive for new GP partners coming in to work in the profession without the burden of premises which they have to buy into. Premises maintenance, I think this is across the board really. We've got quite a lot of significant issues with the with our estate and a backlog in maintenance, and that's generally across the board. And in particular, we've got an access issue with it's emerging within Culloden, that's the medical practice and the surgery. So those premises are currently owned by the GP partners, and they are significantly constrained for space, which is hampering their ability to recruit additional staff. We've been in discussion with them for around 18 months now. We're trying to explore all options with them. We've done a bit of an options appraisal. The practice are now at the point where basically they're looking to formally close their list, and there's an application process that we have to take them through for that. So in the long term, I think what we're looking to do is do a review of our premises for Inverness, but in particular there's a short-term issue that we need to address and work closely with the practice to see what solutions we can put in place. We have the Culloden Clinic, which is next door, so we're also looking at are there services that we can reconfigure across community in Inverness to create some capacity for the practice. So that's just a bit of a quick whiz through some of the issues, Chair. There's many more, but there's just a flavour for some of the pressures and challenges.
Thank you very much, Jill. I'll throw open for questions, but maybe one of the things I would like to come back to, Jill, just if we can, is if we could just get an overview of to the the level of risk sitting within primary care at the moment. We're hearing a lot there, whether it's a buildings risk or whether it's a practice risk. Maybe just think about that when other people are asking the questions. We've spoken a lot at committee about care home risks and care at home and all that. We've never really get into primary care and where we might be in that, with another practice moving back into board management in July 23. But Muriel, I see your hand.
Jill, thanks for that level of detail. That was really, really helpful. One thing I would say that I learnt quite a lot from your run through there. Are we getting our comms right locally in Inverness, particularly regarding the Culloden practice? Because there seems to be a lot of misunderstanding, and I think it's important that we just get our communication to protect the staff and ourselves as well, to make sure that people are informed with fact and not speculation.
Yeah, I'm happy to come back on that one. I think you're absolutely right, and I think any situation that potentially causes confusion for patients in terms of registration is never a good place to be in. We've asked the practice to share some information on their website. There will be some comms when we go through the closure process. There will be some particular comms that we'll put out in relation to how patients can access registration, how they can contact us. We have a role in that in terms of assigning patients if need be. So again, all of that will come through that closure process. In terms of risks, Chair, do you want me to come back on that point? I think we still, our risks around dental, we still have a precarious position in that access obviously isn't what it was prior to COVID. You know, and I think it was documented that some services weren't able to return to pre-COVID levels, and I think that was a particular challenge for us. I think the new contract may allay some fears within the providers. I think the team have quite a bit of work to do to kind of manage some discussions around that ongoing. We've been contracting our public dental services over the period of the last 10 years, and that's because we've had adequate and a rise of NHS dentists. And actually, what we don't want to do is have to get into a position where we have to start contracting that service again. And I think the issue surrounding that is that the workforce shortages within dentistry at the moment, that will be particularly challenging for us to actually to do that. So that's something that we're keeping a very close eye on at the moment. In terms of general practice, what we would be really keen to do is to ascertain what the exact I think state of play is with our providers, our GMS providers, because in the case of Alness and Invergordon, that practice actually failed. And I think, you know, if we knew or had some idea that it was going to fail in the way that it had failed, then is there something we could have done to intervene earlier? So I think we need a conversation with our GP sub-colleagues around, you know, how do we gain that intelligence and that insight around the current state of play for us to be a bit more forewarned if this does happen. So again, there are contractual obligations on practices. It's different for single-handed practitioners than group partners in terms of notice that they serve to the board of their contract. But I think what we would want to do is have some information well in advance of that, with, you know, to prepare us, because actually, you know, we're quite a lean team, and the skills that we're developing around transition from one contractual status to another is quite significant, and the workload involved is quite significant as well. We are carrying risks around premises. We've got premises at the moment that really do need significant investment. We've got a reduced capital allocation as a board, so again that constrains the ability for what we want to do at pace. So the risk register is pretty well rounded. It covers both the GMS practices, our other providers, and also our board managed services as well. So we have those active discussions ongoing on a monthly basis and look at what we can do to mitigate. We currently have 16 whole-time equivalent GP vacancies across our 20 board managed practices. There are various different sizes. We've seen some movement in GPs from some practices to another, so that's really good. So we've got particular challenges in some areas, but in other areas we've had quite a bit of success in terms of recruitment. We've worked really closely with the practices in Malig, Ardnamurchan and Ballachulish, and we're looking at more of a group arrangement down there, similar to what we've established in Caithness. But Caithness and Alness and Invergordon are our two chronic hotspots at the moment. We've got long-term locums in some of the other areas who don't mind working on a locum basis. In Scowrie, Durness, Kinloch, Bervie, they do 2 weeks on, 2 weeks off, things like that. So we're trying to do our best, but yes, we've got significant challenges.
Thank you very much for that update, Jill. I'm not seeing any more hands. There's one, Philip.
Yeah, thanks for that, Jerry. In fact, thanks, Jill. That's quite a comprehensive paper with a lot of information on it. Just going back to cost pressures again, I read in the paper about the dental service with the increase in treatment fees, and I was just wondering, where there's a reference here to the increase in treatment fees, yet the maximum patient charge remains unchanged. Is that going to increase the board costs? And if so, are the Scottish Government picking up any differential there, or is that going to put even more cost pressure upon us?
So as far as I'm aware, Philip, anything that's going to be negotiated or implemented by Scottish Government, I think what they will do is look at the allocation that comes to the boards assigned with that new contract. So the details of that will follow. When it does come, we'll obviously be in a position to share that with everybody. But timescales are quite rapid. A November implementation is quite a significant timescale. So I'd imagine that we'd have quite a bit of communication between now and then around what those reforms would actually look like.
Thank you for that, Philip. Okay, I'm going to suggest that we move on, but just to close that one down, I think what we've been asked to do is to consider a note to the report on the primary care services and accept moderate assurance. And I think a combination of the paper and the excellent update that Jill has given us, I'm happy to do that. Are we okay with that? Lovely, seeing the thumbs up. Thank you very much indeed, Jill. I think you're still in the hot seat, Jill, with the district reports. But maybe if I give you a bit of assistance on this one. What we've done here is members will be aware that for various reasons we've had a couple of meetings, 2 or 3 meetings where we've not had district reports. So Jill's had the team pull together, I think, the full suite of district reports there. So you've actually got the full, I think it's 181 pages there, and I'm not going to for a second propose that we try and work our way through 181 pages there. I think what I would just like to do is maybe just to take 5-10 minutes though, and actually just think about how we use this vast suite of information we've got, how we think we might be able to, if possible, standardize the report, because I think I noted there was a couple of reports in there, a couple of areas in there, Inverness in particular, and Lochaber, that perhaps I think they had the community planning partnership report there as well, which is added to it. So I think that's really, for me, and I'll throw it open to Jill and Pam in a second just to add to that. But that's really is the question for me is what do we do with all this wealth of information that's out there, and how do we use it as a committee? We've had various district managers come to us and present, and they've raised some really good informative issues, and it's how we use it going forward. Jill and Pam, anything you wanted to add to that? Pam.
Thanks, Chair. Yes, recognising that this is a huge document, and the same point as you, Jerry, recognising that, you know, for example, with the Lochaber, we've got the whole you know, added on to the sort of local district profile is all of the additional Loch Harbour data, so we could maybe just put them into links to click on in the district profiles. I think it's really good to see them, to finally have them, because we've been trying to work with them for a long time, and they do really inform a good discussion point in terms of the current services we provide, the costs, the challenges, the areas of good practice, and we should be bringing them into our community planning partnerships. We should be using them to share with our public, to have those discussions and to baseline them. I'm not sure that we can cover them all within our development session, but perhaps we could have an attempt to try and pull out the key areas that match to the transformation that I was talking about earlier, so that we've got that, you know, when people talk about the golden thread, so that people can make the connection about what we're saying in the strategy, the joint strategic plan with the council, what we're actually trying to deliver at the moment, where we're being innovative, and along with our annual performance report, where we need to focus our efforts, and we can maybe articulate and evidence some more key messages for our workforce and for the public. So I think that's where I would like to take them, and I'll open it up to others for discussion. Thanks.
Thank you, Pam. I've got Christopher and then Anne.
Right, I've unblocked myself. Thank you for that, and thanks to all the people who put all this amazing amount of information and data together. I suspect much of it is in Tim Allison's department. There's a lot of work gone in there. However, I am disappointed. Obviously, the population projections are incredibly useful, and I shall store them and use them in future. But I am disappointed that there is so little health data, including obvious things like the prevalence of obesity in different age groups in the different parts of the Highlands. I mean, we really do need to identify the areas of need that we need to address our services towards, and that's a lack, I think. I also note that there are some areas of the Highlands which have not yet been included. Unfortunately, my own ward is not there. We have Easter Ross and Mid Ross, but nothing on Wester Ross as yet. But that's quite easily put right. Later on in the agenda, item 4, I think it is, it says health improvement and refers it back to this to this item on the agenda. But as I said, in the absence of much health data, it's very difficult to see what relevance it has to health improvement. So I think that's disappointing. One other point I'd like to make, in the discussion so far today, there seems to me to have been some confusion between health inequalities and health service inequalities. There have been some people who have talked about health inequalities when they mean health service inequalities, and of course they're two completely different subjects. They're almost unrelated to each other. Obviously, I'm much more concerned about health inequalities than I'm about health service inequalities, but that's enough for me at this stage.
No, thank you, Councillor. But I'll maybe just let Pam come back in that. But I think your points are well made, and I think you're raising the key issue is how do we expand and add to the information so that we can actually use them for health improvement, health planning, etc. So, but I'll let Pam come back in there if she's got a comment to make.
Thanks. Yes, and good points, well made. And you know, the issue around that you raise, an issue around obesity. For example, you know, we do have an annual public health report here. If our colleague and Director of Public Health, Tim Allinson was with us, I'm sure he would be able to frame a good response. But it goes back to the point I made earlier. We need to go through these reports. We need to actually start articulating them, summarising them, so that we can use them in our strategic conversations with our transformational change, with our public and our workforce. So I think it's good to have the totality of the information, and it helps us go back and reframe and get consistency. When I spoke about that integrated model across our districts, you know, making sure that our districts are all going to be understanding the same things, able to have that good conversations with their community and lead transformational change. So I think they're all elements that we would want to pull out of these documents for consistency, and not just accept them as they are, as a submission of profiles across the districts. And some of the districts will have been taking a very health and care focused and prevention element, and other areas will be dealing with remote and rural issues in terms of workforce and challenges. And you're right to make the difference between the health inequalities and health and care service inequalities. So thanks for that. It's good points, well made, Councillor Burt. Thank you.
Thank you, Pam. I've got Anne and then Jo.
So thanks, Jerry. So I think that, Jerry, correct me if I'm wrong, but the idea of the development session was really to discuss the format, what the format, what the content should be, and what the purpose would be for a committee discussion. I don't think, Pam, we're expecting to discuss all of these at once in a development session. In terms of the content, it was more, what are we going to use them for in committee? To what extent do we want to reduce variation, prescribe the content, I suppose, etc., etc., etc. So just to give you some comfort on that front. But I mean, I'm sure this will be an iterative process, but for me, two key things about these reports in terms of how we saw their purpose. One was in relation to our role as a committee in relation to community planning. And we have had an internal audit report on that, which identified some improvements that we need to make in terms of our governance of our involvement in community planning. So, and this committee has a very specific requirement in that respect in its terms of reference. So that for me is certainly one of the key contexts, when we do come to discuss it. And the other was really from a health improvement perspective. I think possibly we need to perhaps think about that the different arenas that these reports might be used in, and that not all of a report might appear in every arena. I would think the kind of information for a local community planning partnership that would be useful might be quite different from what would be useful for the community SLT when they're discussing it. So, maybe there's something about having a broad content, but then cherry picking from that for different audiences. Maybe that was another thought that I had. And just finally, in terms of the data in the report, I'm not sure exactly where we are with our public health colleagues updating all the locality profiles that they produced for community planning partnerships, but I would suspect that some of these district reports have been produced at very different times and might have had access to very different data. So as Pam said, Tim's most recent annual report had a lot of information about issues about the burden of disease across the region and what that means for communities and services going forward. So I'm sure that we can access more of that information for every locality. And just a last thing, one other thing that I found quite useful was that where some of the reports made good use of the IPQR data that we see at this committee. And seeing that at a locality level where possible, I certainly also found quite interesting from this committee's perspective. So just a few thoughts from me, and I think it would be very useful to have a fuller discussion about them at development session. Thanks.
Thank you very much. And I've got I've lost Joe. I've just got Neil now. Well, maybe Neil, if you can come in and give us the final words, and we'll pull this item together.
Well, it's just a quick question, really. Yep, these are great reports. There's loads of information, there's loads of data. They would be really, really useful to lots of different people, forums, clusters, the public. How accessible are they? Where are they? Where can people find them? The same, I guess, would go. The locality profiles, I believe, are on the public-facing NHS website, but these reports.
Jill, do you want to come in?
Yeah, no, I think as folk have said, this is the first time that we've pulled them all together, and I think what we can do is refine them and add to them. And I think Neil makes a really good point. How available are they, and where's the information that we're making in that public facing role? So I think we've got quite a lot to do. We've made a start. But I think how do we actually put them in a format which is more accessible to people? So we're happy to take that away and talk to the team who have been working in the background to pull them together and hopefully streamline that as well.
Anne, I see your hands back up.
Clusters.
Yeah.
Well, well, that would certainly be useful for that work to be done, but you know, these reports are now available publicly on our website, or at least should be. I don't know, Stephen, how quickly things are being uploaded to the new website at the moment, but as they've been committee papers, these will now be available to anybody who can find them on our website. Thanks.
Good point, Anne. So, okay, so I'll just pull this together. I think we've had good discussion there, and I'll chat with Pam in the coming weeks in terms of how we use the development session, because I think, as Anne has said there, we're going to use a bit of time at the next development session to talk about the community planning internal audit, and I think these very much tie into that. But I think there's been lots of very good points made there. But I think the general message, Jill, which you can take back to the teams, is that the reports have been very well received, and like all good reports, that they've set off lots of people thinking about lots of other things which they would like to see. So I think therefore for us as a committee, just to support the people who've done this work and produced this information, to say yes, we welcome this information. We'll probably be back for more, but it would be nice if the generators of the information actually saw some positive outcomes out of that, even if that's actually it being used in the planning and the health improvement arena, as Councillor Burt has said to us there. So we will just note the reports, and we'll note that we're going to have a fuller discussion outside of the committee, but it will almost certainly be at our next or at one after that development session moving forward, and we'll just agree exactly what we want to do there, and that's both in terms of information contained and layout and so forth. So thank you very much for that. So we're now going to move on to item 3.3, which is Children and Young People Services Plan, and I will steal no thunder at all from Joe and or Ian, who are going to present this item for us today.
You're absolutely right, Jerry. It's Ian that's going to talk to you about the children's plan today, so I will hand over to him.
Thanks, Jill. Thanks, Chair. Good afternoon, everyone. For anyone that doesn't know me, I'm Ian Kyle, and I'm here today as the Chair of the Integrated Children's Services Planning Board, to very briefly introduce you to the latest iteration of the Integrated Children's Services Plan 23 to 26. The plan that's in front of you today is a partnership plan that's been developed in genuine partnership and collaboration between public sector bodies and the third sector organisation. The plan is increasingly informed by voice and testimony of children, young people and their families, and an improved understanding of the needs of our communities, which has been determined through a massive piece of work that we've done in producing the Joint Strategic Needs Assessment, which is also included in your papers today. The Highlands Children's Services Plan sits within a context of community planning, and the Integrated Children's Services Board strategically leads and governs the outputs of the plan on behalf of the Community Planning Partnership Board. The plan sets out an ambition of how we can, as partners, all work together to provide services which are organised to deliver high quality, joined up, responsive and preventative support to children, young people and their families. It sets out and clearly articulates our commitments to getting it right for every child, how we can strive to uphold the United Nations Convention on the Rights of the Child, and it really also reaffirms our commitment to keeping the promise. The plan shapes the ways in which we will support Highlands families with respect, care and compassion, ensuring that their voices are integral to everything we do. And ambitiously, I think it states that we'll enable and empower families to thrive, and outlines the ways in which we're going to tackle poverty and support and enable families to live and thrive together well in their communities. I mentioned earlier on the Joint Strategic Needs Assessment, and it's really helped us to identify the 6 themes for the plan. And you'll see that they are, somewhat unsurprisingly, poverty, child protection, corporate parenting, rights and participation, health and well-being, and drugs and alcohol. We've done something a little different in terms of this iteration of the plan, which is in fact the 6th iteration of the Integrated Children's Services Plan, stepping back over a decade of plans. But within this one, what we've done is the partnership's taken a life course approach. And in taking this approach, we believe as a partnership that we can more readily identify opportunities to help minimise risks and enhance the protective factors through our various interventions that you can see within the plan. We call this the 3 stages of our life course: getting started, which is that period of time from preconception to school age; growing up, which is the time when children are of primary school age; and moving on, which is the period where young people are of secondary school age and becoming young adults. And you'll see within the plan that each of the delivery groups has identified their key priorities and change ideas for the next 3 years within these definitions. The plan, of course, factors in the impact of the COVID pandemic on health and well-being, and it also recognises some of the strengths and the unique challenges that there are to children, young peoples and families in Highland. The partnership believes that the enablement and empowerment of local solutions across the wider geography of Highland will improve outcomes for infants, children, young people and their families, and that helps to ensure that Highland is indeed the best place for families to live and to thrive. In terms of the delivery structure, where pre-existing partnership groups exist, what we've done is we've brought them together into the Children's Services Planning landscape. And that's in a bid to improve continuity and prevent duplication across these spaces. So these groups include the Highland Child Protection Committee, our New Promise Board, which was the previous Corporate Parenting Board, and the Highland Alcohol and Drug Partnership. Pre-existing community planning partnership delivery groups also now have discrete subgroups for integrated children's services, and those include those with a focus on poverty and mental health. The plan also sets out the partnership's aspirations to develop a community-based whole family wellbeing approach, and this is a government-funded partnership programme which is now underway, and it aims to reduce inequalities and improve the health and well-being of the Highland population through improving that cohesion, coordination and collaboration of whole family support within our Highland communities. The programme, as I said, is underway, and it's supported by a partnership programme team, which is led by a programme manager, and it's supported by 6 locality coordinators who are just coming into post just now. Finally, just to say that the plan was formally launched last Friday at Inverness Leisure, and at an incredible event, which was called Vision 26, and the event saw the coming together of over 70 organisations and teams across the Highlands. The event was attended by over 500 people during the day and showcased the range of services and support that is currently available in Highland for children, young people and their families. And for anyone who attended, I think would have been impressed by the scale and the opportunities that there were for us to engage and interact and get alongside each other. So thank you, Chair. Happy to take any questions.
Thank you very much, Ian. Just a little bit of background for committee members. Obviously, in our November meeting, we've got Ian will probably be back with us, giving us an update on delivery. But given the timing of the launch of the new plan, I think it's important that we've got then some context for delivery, and we'll see the two fit together. So I'm not expecting lots of questions on the plan today, although we obviously will take the opportunity to ask and answer any that we can. But I think if members could take the opportunity over the next few weeks just to read and take in the plan, the full plan, and that'll give us a bit of the context for our discussions about delivery when we have those discussions at our November meeting. But I see Councillor Burt has his hand in the air, so we will kick off there. Thank you.
Thank you. First of all, I would congratulate Ian on the amazing performance he managed to arrange last Friday. It was astonishing to see how many organisations with relevance to children's health and well-being had stands there and contributed. I commend this report. It contains a very large number of incredibly useful and important proposals, which we must follow through. But Ian will recall that when this was discussed at our council committee, I did point out there is one incredibly major omission, which unfortunately rather dwarfs all the other suggestions in it, and that's the complete absence of anything on diet and nutrition. Well, I mean, I would remind colleagues that children's diet influences more than half of the determinants of their health as adults, including their expectancy of life, their risk of getting diabetes, their risk of heart disease, their risk of strokes, their risk of various cancers. All of these are largely determined by the diets they grow up with and continue with. So I regret considerably the absence of reference to this. It's something we've obviously got to put right, and Ian and I have talked about this separately last week. So I just raised that as a terribly important matter that we need to put on the agenda.
Thank you, Councillor Burt. Ian, any do you want to come back on that, or are you just content that you're having discussions with Councillor Burt outside?
Indeed, but just very quickly to make the point that the Joint Strategic Needs Assessment that sits behind the plan and helps determine the priorities for that has, as you can see from the papers, has many data sets within there. And one of the things that we've committed to doing and reflecting on what Councillor Burt has said is to add to that data set during the duration of the plan, so that we've got broader data around some of the themes that Councillor Burt's raised, and that will perhaps better determine whether next time it does indeed become a priority within the plan. But just to reassure Councillor Burt and other people that this plan does not catch all activity that's undergoing across the partnership, and there are indeed a number of initiatives that are underway to focus in on the themes that is mentioned. Thank you, Chair.
Thank you, Ian. Jo.
Thanks. And this might be on a slightly similar vein, Ian, and it may be that it's implied in the plan rather than explicit, but I'm just wondering about, in terms of the engagement piece, how linked in were armed forces families, and was particularly looking at the disadvantage for service children as they move around the country, given the potential changes we've got around firm base coming into Highland.
Thanks, Joe. And it won't surprise you to know there are many, many partners to the plan. Within the report, I articulated who the members of the board were, but there are many, many other people that are there. And of course, our connection with the armed forces providers is held. And I've forgotten her name, that's dreadful, but someone that I spoke to at length and know very well, who was indeed at the function on Friday, who had a stall there. But we are minded of that and make sure that that's involved. I think, given particularly the reference that's been made in the report to the way that we're going to continue to support families through our whole family wellbeing programme, the fact that that is going to be so community based, and we understand that whilst there are pockets of armed forces people in key areas within Highland, actually that dispersal is amongst all of our communities, and we really need to attend to that as something as we move forward. So it has factored in. It's not one of an overt priorities, but certainly will not be allowed to let that go. Thank you.
Thank you, Ian. Anne.
So I'm not expecting a detailed answer to this just now. I'm more flagging this up perhaps for our November discussion, Jerry. But one of the things that has occurred to me in our discussion, and particularly in relation to Ian's emphasis on the whole family well-being approach that is going to be rolled out, is about integration across adult and children's services. And how good are we in that space? So and you know, maybe again, sort of, I guess, the relevance for the district report conversation we've just had. So I just leave that with people to reflect on, but it would be good to hear something about you know, where we think we are in relation to that in November, when we discuss children's services in more detail. Thanks.
Unmuted. Thank you. I think that's an excellent point. And I think that's really what we should take out of this report. I totally agree with Councillor Burt. It's a plan that's to be commended. And I actually look forward to having fuller discussion at the NHS board. I think in September it's the full plan is coming there. But I think if committee members could take some time over the coming weeks and actually think about it and how it might influence our discussions and what we might want to see in the delivery space, and how we can give that assurance back to the board and that full delivery. And I think it is these subtleties, exactly, or maybe not so subtle as Councillor Butt has said, whether it's diet and nutrition, or whether it's that integration of children and adult, and making sure we've got the full family getting taken care of. And I know we've got committee members who've got particular interests in that transition from children's services into adult services, and making sure that's not lost. So thank you very much. Ian, what we've been asked to today is to note the report, and I think it is note the report for us today. Ian has highlighted the route that it goes through in terms of approvals, and we'll consider it again at the board in September. Thank you very much, Ian. I'm going to suggest that we take the winter planning item, which I think actually will be relatively swift, and then we take a 10-minute break and come back and move into mental health and the drug and alcohol recovery services and our performance items, which I think and I think the remaining items we've got are all, as we've seen across the agenda, all fairly closely linked. So if people are happy with that, we'll move on to the winter planning item, and Pam will take us through the couple of slides that she's got there. Pam. I have no Pam.
It would help if I had put my microphone on before I launched in. So I'm just going to deliver this presentation quickly, because I've framed a bit of this when I was talking about the transformation slides earlier. And important for the committee in terms of the paper then, to see that we had a very robust process last year in terms of winter planning. We actually had some good outcomes at the end in terms of the use of intermediate care beds. We'd opened up a ward within Raigmore that we were managed to move people through the process and out of by the beginning of April. And there was also additional funding from the Scottish Government that the care home sector didn't, take up right across the board, but we did have some areas where there was engagement and extra places offered up for people. So in terms of, I shall just try and add this presentation. It's always the technology that slows you down. I'll just run through the presentation very quickly. It should be appearing now. Can people see it? That's the wrong presentation. Let me just show. I think I'll not bother with the presentation. Let me see. Where am I? Let me just get my paper up and I can talk to it instead.
Pam, I can share it.
Have you got the presentation there, Stephen? I think I've pulled up the wrong one from my files. Well, in terms of the presentation, then, we undertake winter planning every year, and we, have had, this year we've had some upstream winter priorities and actions outlined by the Scottish Government, and a number of the board employees in key roles across urgent and unscheduled care, across planning and strategy, across the acute sector, across community, attended what was called a winter summit that was held in Glasgow on the 22nd of August. So it was good to be there, good to sense check where we are, good to hear about what's happening in other systems in terms of our planning and readiness. From the work that we've done last year, and you can read this in the presentation yourself, we did some learning last year from a very focused piece of work that we had, a task and finish group that was essentially made up of our joint senior leadership teams. So we met twice a week, in terms of being action focused and delivering against key performance indicators that we had delivered, underpinned by our IPQR, and where we needed to make the difference within our urgent and unscheduled care programme board and work stream. So at that point we were working on the high impact changes that I mentioned earlier, and we are now very much focused on our 5 portfolios that have been articulated by the Centre for Sustainability Delivery, and on which we held our joint workshop with last week. So we are in a process, you could call it a PDSA. We're learning from winter planning last year in terms of what went well. We agreed cross-system priorities that were mission critical for delivery in advance of winter, and that was really bringing us all together to agree where our areas of good practice and best outcome would be, and where we didn't have good data in our key performance indicators to improve the data, so that we could work from that informed by data place, and where we understood we had system issues where we could actually focus our activity on delivering, for example, whether that was about communication with the public, about how to use your out of hours services, or whether that was about putting more support into the front door, or developing roles with some of the monies that we had for winter planning to bring people to deliver the process over the winter. So there was clear accountability for the delivery across key actions and across system way with the senior leadership team, and that worked really, really well, because individuals were actually tasked in terms of task and finish around the KPIs and around the delivery. So that worked really well, and it worked well in our system. Through the winter planning process last year, there was a development in a PDSA process around the OPAL framework, which is the escalation framework, when we more get into operational challenges in terms of people coming through the system, then there is a framework that supports us to respond to the pressures in the system that we're experiencing, and it allows us to come around the table and try and work through these. We outlined key priorities that were mission critical for not only the delivery within workforce planning, but that transformational change piece that we were continuing to deliver through urgent and unscheduled care. So winter planning should be seen as something that actually sits within the organisation and that we are continually doing. And of course, we don't just do winter planning, we do all seasons reactivity. And when there's COVID outbreaks ongoing, where we have different infection and control, where we've got seasonal flus in our community, etc. This is business as usual, and through the work that we did last year, we're learning to respond to these in the systems we've developed to support us respond really rapidly. I mentioned the ring-faced inpatient beds that worked really well, and within that we ring-fenced mixed specialty and patient surgical bed capacity as well. So and we had professional nursing and midwifery and AHP-led integrated working around discharge without delay, which is a programme that has really progressed. So it's not specific to winter planning, it's actually a work stream portfolio that has been a high impact change and has been delivering really well. So in terms of the learning, we're well placed to go into our winter planning. So the presentation I'm not going to go through, it's for noting, but I think if you look at the process, then the assurance should be there that we are moving towards this integrated way of workforce planning and being set up for success, learning on the benefits of last year. So we've got a review of our data and intelligence, and we're also learning from other boards and integration authorities. So a good outcome from being all aligned in Glasgow at the Winter Summer Summit. We've got early identification of the workforce requirements, and we're trying to prioritise the retraining of workforce to meet demand, and that's about alignment, it's about community teams, it's about how we configure our services across our hospitals and how we manage that demand and flow and system pressure that we will experience going through the winter. And also we've been looking at recruitment process and staffing solutions around volunteer recruitment, engagement with the community in the third sector, looking at how we can work in a whole system. So, in terms of all of the work that we're doing, in terms of the cross-system leadership, again, that focus workshop, the consensus workshop that we had on the 23rd of August, just last week there, to look across the 5 portfolios and look at what we were doing, and outputs from that should be a clear action plan. We did have a bit of a wash-up session on Friday, and we've got the bones of an action plan leading into workforce planning, which is delivered within all of these profiles. So in that way, then I would provide the level of assurance as moderate to say that this is not about whether or not we can deliver successful workforce planning. The moderate assurance is based on the assessment and the learning that we've had in the setup for success and the state of readiness that we're in going into the winter period 2023-24. So I'll stop there in the needs of being between everybody who's needing to have their coffee break, etc. And I'm happy to take any questions just before we do that to tie up this item. Thank you. Thanks for sharing the title slide there, Stephen.
Thank you very much indeed, Pam. I'll throw it open for any comments, observations, questions that anybody have. But one of the things that really struck me, Pam, when I was reading the report and looking at the slides and so forth, winter planning is almost a bit of a misnomer now, isn't it? It's really, as you say, this is business as usual. And to me, it was that read across between what we were talking about in preparing for winter is actually our transformation journey that we need to do. And actually what's key to this flow is key to this entire operation. And it's not just for the winter, the flow is going to be key to actually getting the system back into balance. Those were just my thoughts. But
Yeah, I totally agree that flow is key, but I also think we also need to revisit some of the protection measures. Remember, there is no shame in wearing a mask. It's good practice to wash your hands and things like that. So I think my own view is that we can't take our foot off the pedal on prevention methods as well, particularly going to hospitals and places like that. So flow and prevention, I would add, Jerry.
Thank you very much, mate. Yeah, a really excellent point. It was noticeable when we were all wearing masks and very conscious of washing our hands, how flu seemed to disappear for a few months. And I don't know if I suspect it was not coincidence. Any other hands? Are we all desperate for a little bit of comfort break? Okay, what we'll do, I think Pam has offered us their moderate assurance on our learning from 22-23 and our planning for 23-24. Are we happy to accept the report as presented by Pam and take that moderate assurance? I'm seeing thumbs up. Thank you very much indeed. So what I'm going to suggest is we take a 9-minute break. My clock says 15:21. We'll come back about 3:30, and with hopefully people will indulge me. I suspect we can be done by about 4:20. Okay, thank you very much. See you in 10 minutes. 9 minutes actually.